The title of my proposed research is Self-Regulation and Behavioral Expectation for Translating Resistance Training Intention into Behavior. Some of the background information that I'll cover will be the health benefits and prevalence of resistance training, and then questions for behavioral research as it relates to the proposed research. And then we'll get into my specific aims and hypotheses, as well as the proposed methods. In brief, there are a plethora of benefits that come along with participating in resistance training. So resistance training can help increase bone mineral density, lean body mass, strengthen endurance, insulin sensitivity. Resistance training can reduce the risk of falls, reduce body fat levels, and also reduce the risk of osteoporosis. Resistance training also reverses muscle loss, increases bone mineral density, and reduces the risk for type 2 diabetes. Resistance training can also improve resting blood pressure and blood lipid profiles, and can improve mental health. Despite the benefits, the current average as of 2017 from the CDC is 30.5%. So 30.5% of individuals are meeting the recommendations of engaging in resistance training 2 times per week. And if we look at the prevalence by age, we notice that as people get older, participation decreases, with the 18 to 24 category having the greatest amount of participation. Another thing that we notice is that there's a steep decline in participation as individuals move from the 18 to 24 age group category to 25 to 34. So the steepest decline for each year that was measured was in that as individuals transition between those two age groups. So there are many health benefits to resistance training, yet prevalence rates are low. So questions for behavioral research as it relates to the studies that I'm going to propose. So what do we need to know? So one, which determinants of behavior are predictive of behavior change, regardless of whether they were successfully changed through an intervention? What determinants of behavior change were successfully changed in an intervention? So if we had an intervention and we targeted certain constructs or correlates of behavior, are we able to successfully change them? And then we want to know if the intervention actually works. Is it viable for changing behavior? Rhodes and colleagues completed a 2017 systematic review looking at the correlates of resistance training behavior. And when they looked at the intrapersonal correlates of resistance training behavior, then we see that affective judgment, self-efficacy, intention, and then also self-regulatory behaviors were all related to participating in resistance training. Rhodes notes that self-regulation behaviors such as planning and self-monitoring are important for people to start participating in resistance training. Thus, models that use self-regulation behavior constructs should be given consideration in resistance training promotion. So based on this, we looked at what models actually included some self-regulatory components, and one of them is the health action process approach. So this is based on a 2019 meta-analysis of the health action process approach by Zhang and colleagues. This was based on health behaviors in general. So what we see here is that task self-efficacy and outcome expectations predict behavioral intentions. In brief, behavioral intentions are translated to behavior with the use of self-regulatory strategies such as action planning and coping planning. Volitional self-efficacy, that is the self-efficacy to overcome barriers, or the self-efficacy to overcome barriers is important for engaging in behavior as well. So Ralph Schwarzer is the creator of the health action process approach, and he says the HAPA represents a mediator model that allows for the prediction of behavior and explains the assumed causal mechanisms of behavior change. He also states that different research questions may employ more parsimonious models of health action process approach. He considers it to be an open architectural framework that serves to guide research and practice. So, therefore, studies may vary in the number and type of constructs that they employ. Because of the flexibility of this model to include certain constructs. So for example, you might see affective attitude, which Rhodes came up as a correlate of resistance training behavior being added to the model. So the health action process approach is a viable model for explaining resistance training behavior. And I'll get into this more, but the proposed model for research is going to include affective attitude. In order to have a more parsimonious approach, we've only kept coping planning instead of action planning as a construct that we'll measure. And you'll notice that we have a construct called behavioral expectation. Behavioral expectation is a construct that was used by Williams and colleagues. Behavioral expectations measure the likelihood of engaging in a behavior when barriers arise, so in the context of certain barriers. And so here's some of these definitions of the constructs that I'm proposing to use. Behavioral expectations is the extent to which one expects they will engage in resistance training given potential barriers. And this is conceptually similar to the volitional self-efficacy that was in the Zhang paper. We have affective attitudes. These are positive or negative feelings derived from the activity. Intention captures the motivational factors that influence a behavior. They're indications of how hard people are willing to try and how much of an effort they're planning to exert in order to perform the behavior. We have coping planning, which is a barrier-focused self-regulation strategy. It represents a mental link between anticipated risk situations and then suitable coping responses. And we have task self-efficacy. So self-efficacy is beliefs about capabilities to exercise control over behavior. So what determinants are predictive of behavior change? So we see affective attitudes, intentions, self-regulation, and self-efficacy, all those being important constructs based on that Rhodes paper. So what determinants of behavior change can be successfully changed in intervention? There's relatively scant research on resistance training where researchers are trying to actually enhance certain constructs. So this table just represents all of the current research where constructs have been attempted to be modified, and we'll pay most of our attention to the bottom 3 studies on this table. So in one study by Lubins, participants in the intervention group actually significantly increased their resistance training planning strategies. We saw that the intervention did not actually impact intentions, task self-efficacy, or outcome expectations. So in the Lubin study, self-regulatory strategies, specifically planning, were malleable to change. And here we see the control group actually reduces their RT planning strategies, whereas the intervention group increased their resistance training planning strategies. So in this study, we're seeing is planning as a construct that is malleable to change. We look at Millins and Bray compared two groups, and what they found was the intervention group scored higher than the control group for technique self-efficacy and also for adherence self-efficacy. So that's confidence with their technique, and then confidence that they could adhere to doing resistance training for a certain number of days. So technique self-efficacy increased. And then we look at Williams' paper. Williams found that participants in a high-dose resistance training promotion, that was a behavioral coaching aspect of it, had more positive changes from time 1 to time 2 than participants in the low-dose intervention for behavioral expectations and self-regulation. So we do see that some of these constructs that I had mentioned are malleable to change. But what I want to add, and this is prior to Williams conducting his paper, this is in the review section. He says, taken together, these studies show little consistent support for the malleability, predictive power, and mediation of social cognitive constructs. And they say, with the possible exception of some self-regulatory strategies, i.e. planning. So what determinants of behavior change or successfully changes intervention? What we see so far is seems like we can change planning, seems like we can change behavioral expectations, and task self-efficacy as well. So now we want to know, if we know what is related to behavior, what can we change? And we want to know, is the intervention viable for changing behavior? And so mediation tester might be useful for answering that question. So in Williams' paper, we saw that changes in self-regulatory strategies mediated the effects of the intervention onto behavior. So when you change self-regulation, you change behavior. And then behavioral expectation nearly met that lower bound confidence interval for significance. So it was almost there, but it wasn't there completely. Lubin's, that was the one where they increased planning. So increases in planning mediated the effects of the intervention onto behavior as well. So it seems as if changes in planning contribute to changes in behavior. And we'll draw back from what Rhodes said. One of them is going to be a repeat of what I've already said. But Rhodes says resistance training interventions should include strategies to target these key variables. So task and barrier self-efficacy might be important, especially important considerations. So people need to feel confident to do resistance training behaviors. It's task self-efficacy. So they need to feel confident in their ability to actually execute the behavior. They need to feel confident in their ability to overcome barriers. And this is a repeat too, but self-regulation behaviors such as planning and self-monitoring are important for people to start resistance training. Thus, models that use self-regulation behavior constructs should be given consideration in RT promotion. So what we're seeing here is placing a premium on 3 of the constructs that I had mentioned in the model. Task self-efficacy. So they actually have to know how to do the exercises. We also have barrier self-efficacy, volitional self-efficacy. What we're using is the term behavioral expectations, so the likelihood of participating in a behavior despite barriers, and then also self-regulation, so specifically barrier-focused self-regulation, planning to overcome barriers. So based on what we know from the limited amount of resistance training research, we can move into the specific aims and hypotheses, especially as they relate to the questions for behavioral research. So in study 1, I'm going to seek to examine the effectiveness of the conceptual model that I had previously shown, which is based on the health action process approach. This model is going to include affective attitudes, task self-efficacy, intention, coping planning, and behavioral expectation. And we're looking at the influences of these constructs on intention and also resistance training behavior. So the first hypothesis is that it's hypothesized that task self-efficacy, affective attitudes, and behavioral expectation will predict intentions. It's hypothesized that intention, coping planning, and behavioral expectation, those are the direct routes to behavior, so they will directly predict behavior. It's also hypothesized that the relationship between intention and behavior will also be partially mediated by coping planning and the behavioral expectations. And this is going to be the model that I would be testing. So again, task self-efficacy, affective attitude, predicting intentions. We have intention, behavioral expectation, and coping planning, all predicting behavior. And then the effects of intention being mediated onto behavior being mediated by behavioral expectations, and then coping planning. Study 1 will be a survey study. It will be a longitudinal survey study. Study 2 is going to be proposed to be a randomized control trial. So there's 2 aims to study 2. The first is to examine if task self-efficacy, behavioral expectation, and coping planning are subject to change in a resistance training intervention. So if these constructs are related to behavior, can we successfully change them? And the hypothesis is that all participants will enhance their task self-efficacy with guided practice. Everyone's going to get guided practice in this study. However, the randomization is going to occur on behavioral coaching. So participants in the guided coaching group will enhance their behavioral expectations and coping planning. So we propose that the intervention will enhance those constructs. Specific aim 3 is to test if participants who receive a behaviorally enhanced resistance training intervention, which addresses behavioral expectation and coping planning, engage in more resistance training sessions than those who receive usual care resistance training intervention. And we hypothesize that the enhanced guided coaching intervention, which is resistance training plus guided coaching, will engage in significantly more resistance training sessions than just a usual care group that just does resistance training only. So now we'll cover the proposed methods for both of the research studies, starting with study 1. So study 1, proposed methods. Again, the purpose of this study is to test a conceptual model in a non-clinical healthy population. So for the participants, healthy is going to be defined as those individuals without serious injury, long-term physical incapacity, or suffering or rehabilitating from chronic conditions and risk factors that require medication. Participants are going to be college students and faculty from a university in the New England region. We're going to recruit healthy adults aged 18 to 35 who have engaged in resistance training at least one time in the past 4 weeks will be considered eligible. So the sample size for this is based on a few things. First, we're looking at recommendations from Klein. Klein says that samples with less than 100 participants are small, those being 100 to 200 medium, and samples with 200 or more are considered large. Klein also recommends that for every parameter, there should be 10 participants. So with 5 estimated parameters, at least a sample of 50 or more participants would be needed for the analysis. If we also look at effect sizes for coping planning and run a power analysis, we see in order to get a medium to large effect size, 89 participants would be necessary. So just factoring in potential dropout and also the recommendation of Klein, we want to aim to recruit 120 participants to put us at least in the medium group. So how are we going to get participants? We're going to have several active and passive recruitment strategies that will be conducted, including classroom visits, poster placements, and then campus-wide emails. So the principal investigator, myself, will actively recruit participants through on-site classroom visits. Professors from various departments will be asked for permission to begin classroom visits, where the principal investigator will explain the purpose of the study. Again, passive recruitment techniques, those are going to include placing posters by high traffic areas, such as changing rooms in the student gym, outside the student gym, and by water fountains in the student gym. So campus-wide emails will be sent out as well with an attached Qualtrics eligibility survey. Interested participants will be instructed to email the lead investigator to receive the Qualtrics eligibility survey. The eligibility survey is going to look like this. So participants are going to be asked their age. If people are younger than 18 or older than 35, that will make them ineligible. And because we're studying current behavior, we want to make sure that participants have engaged in resistance training at least one time or more in the past month. We also want to make sure that participants don't have any contraindications, so they'll be filling out Part Q. If they have any contraindications, that will make them ineligible. If they're 18 to 35, have done resistance training at least once a month, have no contraindications, we can have them consent to the study, so they can sign an informed consent. Once they've signed the informed consent, the participants will complete the survey. And here's a quick summary of all the measures that I'm proposing to use and the references as well. So affective attitude is going to be 3 questions, assessing positive or negative feelings associated with resistance training. Task self-efficacy is going to be questions that will assess participants' confidence in their ability to execute selected exercises with proper technique. We have 4 questions that will probe participants about their commitment and motivation to engage in resistance training, and this is going to be for intentions. Behavioral expectations, so it'll be 10 questions that assess participants' confidence to overcome barriers to do resistance training. And in coping planning, there'll be 5 questions which assess the extent to which participants have made plans to overcome barriers to resistance training. And then to measure behavior, which will occur in a 2-week follow-up, we'll use a modified International Physical Activity Questionnaire. This will be the same one that was used by Peach and Lipke in 2017, and the questionnaire will ask participants to report the number of days of resistance training they participated in the last week, and also the average duration in minutes. Once participants have completed the follow-up survey, they'll be sent a $10 Amazon gift card. And once we have all of the data, we'll be able to do our analysis, and the initial analysis can be done prior to getting behavior as our last variable. So we can predict intention right off the bat with all the constructs that were given to us. So we can have these 3 constructs: affective attitudes, task self-efficacy, and then behavioral expectations, predicting intention. We could also predict coping planning with behavioral expectations and intentions. After the 2-week follow-up, once we get behavior, we'll be able to run and test the full model, again with intention, behavioral expectation, and coping planning, all predicting behavior, and with the effects of intention also being mediated by behavioral expectations and coping planning. Moving on to Study 2 proposed methods. Study 2 will be a randomized control trial, and that will be a study in which participants are actually engaging in resistance training. So what we have to do first is actually train the trainers, the people who are going to be doing the resistance training coaching to the participants. So prior to the commencement of the study, student volunteers with personal training experience will be recruited by the principal investigator to be trained to serve as personal trainers for the study. Now, students with personal training certifications and upperclassmen status will be preferred and actively recruited. The volunteers will be recruited via university internships and also independent studies and through the student gym, which employs student personal trainers. And we're going to recruit up to 3 student volunteers. Here's an overview of how the study is going to look. So we have 2 phases. So we have a guided resistance training phase and then a randomization phase. So starting with the recruitment phase, though, we'll be recruiting participants in the same way that we recruited participants for the study number 1, based on the effect sizes for coping planning, and then also looking at the sample sizes from previous randomized control trials. The power analysis revealed that 47 participants will be necessary to detect a medium effect size. If we look at what's been done in the past, so Lubins had 48 participants, Millen and Bray had 41. Williams was the exception; he had 123 participants. So for the first 2, we're in line with the sample sizes that have been used in previous research. So how are participants going to be eligible? So 1, they need to be 18 to 35 years old. There's going to be questions about resistance training as well. So what we want in this case is a little bit different than in study 1. We want people that are novices. So we want people that on average participate in resistance training less than 1 time per week. So for example, if they did 4 times in the last 4 weeks, then they wouldn't be eligible. But if they did 3, they would be eligible. So we also want them to have no contraindications. Once participants have been deemed eligible, they'll provide an email and a cell phone number for the primary investigator to contact them to get them all set up. So once participants have been recruited, they'll begin to move into the guided resistance training phase of the study. So the resistance training intervention is going to be broken down into 2 phases, as I said before. In the first phase, all participants are going to receive guided instruction. The first phase is going to last for 2 sessions. During the second phase, participants will be randomized and given a program to follow on their own. These sessions will not be actively led, and this phase will last for 6 sessions. So in the first phase, though, in the first 2 sessions, all participants will come in after they've consented. They'll be given a resistance training notebook by their trainer. The resistance training notebook is going to have all the exercises written down that they're going to be doing. And then the trainer will teach them how to actually track and write everything down that they're supposed to be doing. So to receive a fitness logbook, they're going to start with a 2 to 3 minute warm-up that's just going to basically warm up the entire body. And then they'll go into the resistance training program, which is expected to last 35 to 40 minutes. So the training program, again, is going to be executed by the student volunteers. The exercises are going to be a dumbbell press, a goblet squat, dumbbell row, a dumbbell overhead press, step-ups, band-resisted curls, and then band-resisted tricep extensions. The training sessions will also consist of 3 sets for each of these for 10 repetitions for each exercise, and participants will rest 60 to 90 seconds between sets. And what we're going to do is we want to keep participants in a somewhat challenging rate of perceived exertion zone. So participants, the student trainers are going to ask participants how tough that exercise was using the modified Borg scale. So we want it to be somewhere in between somewhat hard and hard. We're not going to push into the very hard range. And a quick recap of all these measurement time points. So during the first 2, and after the end of the first session, we'll measure task self-efficacy and affective attitude. At the end of the second session, prior to randomization, we're going to measure all of these constructs. We're going to measure task self-efficacy, affective attitudes, intentions, behavioral expectations, and then coping planning. And then participants, so here's just a quick example of what the measures are going to look like. So because we're measuring specific exercises, competence for specific exercises, each question is going to have an image next to it for each exercise. So for example, my confidence to do this exercise, which is the dumbbell press, using proper body positioning, and the appropriate amount of resistance is, and the correct movement is. So self-efficacy for each item is going to be rated on a scale from 0 to 10. And then we're going to have an average for each exercise, and then we'll have an average self-efficacy score for resistance training. And these measures are going to be assessed by the primary investigator, not the trainers. So moving into randomization, there's going to be an experimental group, there's going to be a control group. So at the end of the second guided session, all participants will be informed of the resistance training guidelines, so 2 times per week. They'll receive a printed educational packet on the health benefits of resistance training, along with a printout of each exercise they have done with detailed instructions. The resistance training program in the second phase is going to be identical to that of the first. So that's when they'll be practicing the exercises that they learned. The difference now is that the resistance training will be self-guided. All participants are going to be given a schedule of open hours for which they can return to do resistance training. And both groups will be informed that after the 3-week period is complete, that they'll be given the option to sign up for additional training sessions as a thank you for their participation. So in this case, they'll learn new resistance training exercises, and then we'll be able to get them back for final measures too. So in the control group is just going to continue with usual care. They get open hours, they have their resistance training tracking notebook, and they can come in during any of those open hours to do their resistance training. But the experimental group, we're going to do behavioral coaching, and we're going to intervene on these constructs, behavioral expectations, and coping planning. So now I'll cover what the experimental group is going to get into. So upon randomization, the experimental group is going to get a daily planner that's going to look something like this. We're going to go through several behavior change techniques to enhance behavioral expectations and then coping planning. And the first one's going to be time management. So they'll be given a notebook and they will write down all of their commitments for the next week. So once they write down all their commitments for the next week, we can start to think about when they can fill in resistance training. So they're going to fill in their weekly schedule for the next 7 days and then move on to the next section when they're done. So they'll flip the sheet that has all these these behavioral coaching aspects on them. So for action planning, what we want to do is we want to determine the best time for them to come in and do resistance training. So action planning is going to be linking the behavior with the situation that prompts them to do the behavior. So in their notebook, they'll have the empty space on the bottom right side where they'll write an action plan for doing resistance training. So for example, their action plan might be, after my biology class on Monday, I will go to the gym to do my resistance training. And they'll end up writing that down. So it will look a little bit something like this. So in this blank space, after my biology class on Monday, I will go to the gym to do resistance training. In order to work with coping planning again, participants are going to be given pervasive encouragement. So what will happen is we will ask participants for a requested reminder date and time for when they were going to come in to do resistance training. And because they're planning out the next 2 sessions, we'll send out 2 reminders. So if participants wanted to come in on Tuesday at 6 p.m. to do their resistance training session, they'll tell us when they would like to be reminded and then at what time they would like to be reminded. And then a reminder message will be sent out to those participants at the time that they are requested. The coping planning is a barrier-focused self-regulation strategy, and it represents a mental link between anticipated risk situations and suitable coping responses. In their daily planner, participants are also going to identify barriers to engaging in resistance training and write out plans to work around these barriers. So this is the script that they'll be getting, but this is what it will actually look like in their notebook. So what they'll say is they'll think about any potential barriers that they might have and then write a plan to work around it. So for example, if I miss my resistance training session on Monday because I have extra work to do, I'll email the research coordinator to make up a time to do my session. And sessions will conclude with making plans and thinking of potential barriers along with solutions to the barriers. once we've gained all of the data, we can begin to do an analysis. So in the first analysis, we'll have an action theory test. So we're seeing if we actually enhance the construct. Specifically, did we enhance task self-efficacy? Did we enhance behavioral expectations in the intervention group? Did we enhance coping planning in the intervention group? So in the first phase of the analysis, we'll test the effects of condition on changes from time 3 through time 5 on coping planning and behavioral expectation. Regardless of condition, we will track changes in task self-efficacy from time 1 to time 5. And we'll have a repeated measures they know will be run to analyze the difference in task self-efficacy scores for all groups at all measurement points. So we want to know, is there a difference between the control group and the intervention group on these constructs? So repeated measures they know will be run in the self-regulation and the behavioral coaching group for coping planning and behavioral expectations at all time points as well. At the end of the study, we'll also be running an independent samples t-test to determine if mean scores between the self-regulation group and the control group at the conclusion of the studies for all constructs, including behavior, were different. So at the end of the study, is self-regulation greater for the experimental group than the control group? Did the experimental group engage in more resistance training than the control group as well? So just as a conclusion, based on the two studies that I proposed, we will be looking at these three questions for behavioral research. So one, which determinants of behavior are predictive of behavior change regardless of whether they were successfully changed through an intervention? So that's going to be addressed in study 1 with model testing. And then we have what determinants of behavior change were successfully changed in the intervention. This is going to be addressed in study 2. So we're looking at, can we successfully enhance task self-efficacy, behavioral expectations, and coping planning? And then lastly, is the intervention viable for changing behavior? Did the intervention that we use, where we aim to enhance coping planning and behavioral expectation, did that actually change behavior?